Uh-oh, we're in trouble.
And actually,
Okay.
okay.
All right. This is the Kern Valley Healthcare District Board of Directors meeting of April 7th. And calling this meeting to order. The first item of business is approval of the agenda, which includes, well, we'll do approval of agenda first. Are there any changes to any board members have any changes to the agenda?
Correction I wanted to make on our minutes, but is that now?
That's consent.
Oh, that's consent. Okay, sorry. No,
that's okay.
That's good.
Okay. Any staff members or members of the public care to provide any input on the agenda? Okay, then I need a motion to approve and a second.
I'll move to adopt the agenda as presented.
Thank you, John.
I'll
second, Ross.
Fred, second. Okay. John, Fred. So we'll assume you are yes votes since you made the motions in the second. Jean, are you okay with this?
Yes.
And Catherine?
Yes.
And I'm a yes. So agenda approval of the agenda is approved. And our flag salute will be led by our CEO, Tim McGlue.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. And Mark, I think you got the next piece there.
Mark, are you able to do our invocation?
Absolutely, yeah.
Thank you.
If those of you who would care to join me, Heavenly Father, we're so grateful for your presence in this meeting. We ask that you give us guidance, give us prudence, give us a diligent approach to all of the decision making that goes on in the board meeting for the Kern Valley Healthcare District and for the future treatment of all of our residents of the Kern River Valley. Thank you, Father, so much for looking over, watching us, guiding us, and protecting us. Give us prudence in Jesus' name. Amen.
Amen.
Thank you, Mark.
Thank you, Mark. Thank you, Tim.
You're welcome.
Our mission statement is provided there on the agenda. Please take a look at that. And item C on the agenda is for public comment. This time is reserved for members of the public who want to address this board on matters that are under our jurisdiction but are not on tonight's agenda. Do we have any members of the public wishing to be heard? I see none stepping forward. Then we'll move on to the consent agenda. And the consent agenda are items that staff and committees have determined they're non-controversial and routine, and all of the items on the consent agenda will be approved in one motion, unless any board member or member of the public requests that an item be removed from the consent agenda so it can be discussed in its in a regular place on the agenda. So I know, Jean, you had a question or a correction on minutes.
Yeah, a question or an objection. I don't know what it is. You want me to say it now or just hold it?
Please.
Okay. At the meeting, I asked Heidi, and I know Heidi does what she's told.
Which one are we talking about?
The finance.
Okay, finance minutes. All right.
Right. To put on the agenda to discuss why we don't have a contractor. And she sort of agreed to it, but I know it's not her. She does what's told put in there. It's like having the surgery without a surgeon. I cannot believe we don't have a contractor.
You won't have a contractor until you have the plans all done. Because the contractor would need to know what to bid on.
Well, how can we borrow money on something? We don't have a clue how much we really need until a contractor really looks at it.
Well, it's all built into the budget.
Guys, this is not.
Okay, all right.
Right.
Okay, so.
I asked Heidi to not put that on the agenda. She had asked me about it, and I said, it's not appropriate at this time.
Okay,
We can either discuss it during the Building and Planning Committee meeting, which we didn't have.
We don't have one.
Well, we missed one this month, but we'll have another one.
You're supposed to call every board member. You agreed to it to see if they had input. I didn't get a call from you before you canceled it.
Yep, I should have done that. I apologize. You're absolutely right.
Okay,
Won't happen again.
And the other thing, a committee chair has the right to put something. You should have called me if you didn't want it on there.
You know, I guess we should have discussed it. I didn't think it was finance related. I didn't think it was a finance committee business.
Well, if it's...
Yeah, so we can discuss this during director comments on items not on the agenda or offline if you would like.
Okay, well, then at the comments area, then maybe it'd be a good time to talk about it. Thank you. And Russ, I wasn't giving you a hard time. I was just trying to get myself corrected where I'm at and what's going on.
Yep. Thank you, Gene. Okay, so back to consent agenda. Are you requesting that the Finance Committee meeting minutes be withdrawn from consent?
No, that was the reason I clarified it, so it's fine, the rest of it. So.
Okay, Gene, thank you. Any other comments or concerns, any items wishing to be removed from consent agenda? Okay, seeing none, then I'll entertain a motion.
I'll make a motion to accept the consent agenda as it is.
Catherine, thank you.
I'll second.
Gene, second. Okay, Catherine, Gene, I'm assuming your yes votes. John, your vote?
Yes.
Fred, your vote?
Yes.
And I'm a yes. Okay, consent agenda is approved. Which brings us to item E under reports, which brings us to foundation report. Do we have anyone present? Is that you tonight, Debbie?
That's me. Good evening. So I have a few things to share with you. We're getting ready to send our second payment to God's Storehouse and the Food Pantry for $500 each, and that was from the anonymous donor. Well, we are still working with the third agency to get their paperwork in order. We feel promising that we're going to be able to do River Rhythms. All of paperwork's been sent to the county. The county's personnel will be back in the middle of June. And if things continue going in the right direction, we're pretty sure we'll be able to have River Rhythms. We've got the bands all confirmed. This month on April 30th, we're hosting the unused medication drop-off, what we did in September. So we're doing it again on April 30th. It'll be held in front of the Mount Mesa Clinical Pharmacy. And that'll start at 10:30 till 1 o'clock, I believe. We have our auxiliary appreciation lunch that we didn't get to do last year, and that'll be on April 28th. I know some of the board members will be planning to serve and participate in that. We have our employee appreciation dinner, or lunch rather, provided by Walmart. That'll happen on April 21st. And Hospital Week is coming up. That'll be from May 9th through the 15th. The Activities Committee has a lot of good things planned, and hopefully we'll see some of the board members during that time. Any questions? That's my report.
Thank you, Debbie. Any questions for Debbie?
Well, would it be serving like
we've done in the past?
Okay, so we're okay to do that.
Yes.
Yeah.
Okay. Now, should I wear a hair mask or a face mask?
We'll probably give you a hairnet and a face mask.
Is Judy still the president of the foundation?
Yes.
Yes.
Okay. I just haven't seen her in forever.
Well, she's out there working. She's busy.
Okay. I'm just hadn't seen her in a while.
Okay, item 2 under reports, auxiliary report.
We'll give that report for the auxiliary. Good evening. So things are going great at the gift shop and the thrift shop. We are still open Monday, Thursdays, and Saturdays, but sales are great and donations are coming in. Most everyone now knows to drop off donations when the store is open. That was an issue where people were just dropping them off when they weren't and just leaving them there. Then we were having issues with people coming by and just picking through stuff and driving off with it. So, which obviously cost the hospital when they did that. So again, that's what we've been trying to do, is to kind of limit the deliveries or drop-offs of things like that. So this is, we're having a big bag sale this week, $5 for all the clothes you can put in a brown shopping bag. The public loves these sales. We are anxiously awaiting the appreciation luncheon here at the hospital on the 28th. That will be fun to see the sea of pink again. And then once again, I would love to invite each of you, the board members, and every one of you to come down and see the daily operations of the thrift store. So thank us, respectfully submitted by Cindy Rupert.
Thanks, Tim. Any questions for Tim?
It's nice having her to give the report, but it's so you're almost as good.
Okay, moving on then to item number 3, medical staff report. Dr. Finstead, are you here?
I am here. Thank you, and good evening. So let's see. The Bioethics Committee met on March 8th and discussed the ethical challenge associated with the ongoing pandemic, including protection, prioritization of healthcare workers, and also discussed the use of databases for health information related to the pandemic. The Pharmacy and Therapeutics Committee met on March 15th. We discussed the COVID-19 issues, along with some approving the formulary for the clinic. We reviewed and approved 7 policies, including sterile compounding, policy regarding patients' personal medications, medication error management, admission process, IV access and maintenance, along with the hand hygiene program, and also reviewed the expanded precautions regarding transmission-based issues. We added a medication to the formulary regarding pancreatic insufficiency issues. Then we reviewed our regular reports on blood usage, blood culture analysis, medication error prevention program, and medication shortages. The executive committee met on March 23rd. Both the lab manager and the PT managers were present by Zoom, discussing issues regarding their departments and new programs. Particularly for the lab, it was their new rapid COVID PCR capability. We reviewed and approved the 7 policies that were in the consent agenda. We also reviewed and approved 2 credential files for Dr. Burrows and Dr. Newell, which were approved in the consent agenda. We discussed records retention for Infection Control Committee and decided that keeping records for 6 years was adequate. We have records going back quite a long time, some of which are obviously not accessible through digital means. We discussed updates on the use of COVID-19 medications. We reviewed and discussed changes to our bylaws. This is an ongoing process. And then we reviewed the action reports from the California Medical Board and the Osteopathic Medical Board. And finally, the Infection Control Committee met yesterday. They discussed masking guidelines and set up an ad hoc committee that will bring recommendations for changes. This was specifically related to people wearing or not wearing masks in non-clinical areas, and vaccinated versus non-vaccinated staff. They also reviewed their regular monthly and quarterly reports, including employee exposure, hospital-acquired infections, blood culture analysis, and hygiene, and antibiotic usage, both in the acute care and the skilled nursing facility. and also discuss the environmental care rounds, both for acute care and the skilled nursing facility. And that's pretty much the end of my report, unless anybody has any particular questions or anything.
Any questions for Dr. Finstead?
I don't have any.
All right. All right.
Gary, I have one.
Sure, go ahead.
Regarding the infection control and mask wearing, are we following CDC guidance on that? Is there some other source that we use for that? And is it appropriate for medical providers to no longer wear masks if they've been vaccinated? Are we there yet?
I don't think so. I don't think there's any recommendations for not wearing masks in any type of clinical situation. And now I think there are other situations that may be more applicable in clerical situations, for instance, medical records and things like that. I was not present at the meeting, and I don't know exactly the issues that that Greg Davis brought up and things. Maybe somebody else could speak to that if they were there. But I think as far as in any type of clinical situation, I think masks continue to be required. The main concern is, or one of the main concerns is exposure to the new variants and things. I know, for instance, at our office, all the providers, all the staff have been vaccinated, and an increasing number of patients have been fully vaccinated, but everybody is still required to wear masks. And I don't think that's likely to change in any type of clinical situation, both from county, state, and CDC, guidelines on that.
Okay, I appreciate that clarification. Thank you.
Yeah, I'd like to add on to that, Ross, if I might. Again, the issue, again, that kind of brought this to light was the fact that we actually did have one of our employees who became positive and works in a relatively small office with other staff. And the issue is they felt safe that they could wear them in the office, since they just worked with those same people all the time. Well, that had the potential to literally shut that department down for 2 weeks. Wow. This is a non-clinical area and so forth. And as we talked about that, there were a couple of other departments in the hospital that were doing similar things that felt like, since they were in their own areas, that was okay. And they weren't getting out and traveling around the facility. But again, I think just as we saw, all it took was one individual to get sick, and we literally could have shut that whole operation down. Mm-hmm. And so that was really the need that came out of why we need to go back and relook at this. And even though some of our people are being vaccinated, as Dr. Finstead just alluded, again, we have variants that are coming out. And, there's an issue going on right now in Michigan and several other places where even fully vaccinated people are now coming down with COVID because they're getting now one of the variants, either the UK one, or I believe it was the Brazilian one, and also the UK, or the South African one. So, again, and some of those, the variants may not be as readily covered as the original, virus was. So anyway, again, it just kind of forced us to go back and relook at our practices and so forth. And like I said, infection control came up with a policy that's been being reviewed through various committees here in the hospital and so forth that will hopefully stiffen up some of those requirements. So again, it's for everybody's protection. Like I said, it's still here. We don't know yet. There's predictions coming that there might be a fourth wave coming because of the variants. So, again, I think it's still safe practice. The governor this morning was even talking about how he's going to open up the state by June 15th, but even with that, it's still called for certain mandates for masking and those kinds of things. So, I think it's a good practice that we need to go back and relook at. So,
Dr. Finstead, can I ask you a question? This
Sure.
Crazy question, but is there any negative effects? Like, I have a hard time breathing anyway, and it's more difficult to breathe through the mask. Is that long term? Should I just stay out of where I have to wear it, or does it have no effect?
So I don't think there's any evidence to show that it has any real significant health related effects. I think most of it is just discomfort. I think it's one thing to wear a mask when you're just kind of working at your desk and things. I think the other issue is when you're talking. I know personally for me, when I'm talking to a patient in the exam room, I mean, it gets pretty uncomfortable after a while, you know, and things. But as far as, you know, any effects on your oxygenation or CO2 levels, I think those are really likely to be very insignificant and things. Stuff our body's very capable of.
They talk about you wear a face shield.
Well, it fogs my glasses up and I sign in the wrong places.
Yeah. Gene, that's not really a medical issue.
So I'd like to chime in here just for a minute, if I may.
Yeah, sure.
Our policy has always been that every department in the hospital must wear a mask. That's the CDC recommendation. Whether we're following that or not is a different story, but the fact remains, no changes needed to be made. Enforcement needed to be made. So I just want to make that very clear.
Thanks, Mark.
Thank you, Dr. Vincent, for answering my question.
Any other questions?
So we're redoing a policy about wearing the mask for infection control purposes?
No, I think they're going to set up a committee. That's my understanding from the report I got from that, to take a look at this. But I think clearly what Mark said really is, I mean, we're a healthcare facility, you know, so on our campus, I think unless you're alone in your office, you know, doing, you know, working by yourself, I think really there's just not a variance like that that's really going to fly.
So it's more of an education again.
Yeah, and I think education, what Mark said, you know, enforcement and things.
Okay, thank you.
All right.
Thanks, Dr. Finstead.
My pleasure.
All right, item 4, Chief Executive Officer report. Tim McGlue.
Thank you. Just working through some issues right now. It was a piece of legislation that was passed called SB 95, which basically called and required all businesses with 25 or more employees to implement a supplemental paid sick leave program for their employees, which basically provided upwards of 80 hours for full-time employees in additional paid sick leave for if they came down with COVID and had to be put off, if they had to be quarantined because of that, either themselves or family members, if they had to go home and care for a child or whatever because of COVID, those kinds of things, they were eligible to get another up to 80 hours of time. That was to be used before they went into their regular time off bank. And this was done like about 2 weeks ago, I believe it was. It came out on a Friday. We had until March 9th or 29th to get this thing in place and be compliant with it. I want to thank Heidi and Barbara and Deb Hoffman for all the work that they've put in and their staff to help us get to that. What the big problem was, they made it retroactive to January 1st. And so, which we had a week, basically literally 1 week in which to put this thing together. And get all this stuff done. It was a big undertaking.
Yeah, I remember that all happened during the policy and personnel committee meeting, and you brought that up. It's like, oh no, it's due today.
Right.
Really?
Exactly. So anyway, they've done a great job on that, and we're ahead of that. This will continue on until I believe September 30th is when that will expire. And again, came out. We had it in place before, but it was a federal program. Which didn't affect us because it was only for employees. Hospitals were exempted, but it also affected businesses of 500 people or more. The state came in and did their own program this time, which dropped that requirement down to 25. So it made it much more onerous for people to comply. So anyway, we are working on that. Anything either of you want to share on that, or if not?
Ready to be done.
Yeah, I know, it was a huge piece.
Well, thanks for doing it. I know it's kind of a.
It's mostly Barbara. She's got the hard part.
Yeah, because the issue is your paychecks have to show the hours, the supplemental hours on there that you have that are in addition to your bank. and so forth. So we had to modify the time cards, obviously, accordingly. So this was a huge thing.
May I ask, Barbara, like how much more time does that take you in the office having to do all this? I'm just curious, because I know it's an overwhelming undertaking to have to do all this.
Well, luckily the retro didn't affect all that many employees.
Oh, okay.
So once we got that all sorted out, then it was easier to.
That was the biggest part of the mess, trying to make sure.
Okay, right. We got to go back and identify anybody who was off on time, and we may not have known about it or whatever. They may have just taken time.
I'm a little bit confused. You said it was first, the money was taken away from the 80 hours first?
You had to
no matter what it was?
No, it had to be for COVID related issue, right? Right. Yeah. So if they, like I said, if they had COVID and had to be sent home for 2 weeks, or if they had quarantine for
if they 10 thought days. They had it, did they still get it?
If they were off due to an exposure until their negative test came back, that would qualify as well.
And yeah, like I said, the retro piece was a little harder because obviously we had to go back and figure out who actually did, and we didn't always know, and so forth. We can kind of tell for when they took time off and so forth.
I think that we knew the majority, so it was just a matter of making sure we had identified them and verifying the dates of work that they had missed as a result.
Then we had to go back and put those hours back into their banks and so forth and deduct it from their 80 hours, and so forth. So just a lot of work. But again, I appreciate the effort that they made to get this done timely. And so obviously going forward, it's a whole lot easier than it was going backwards.
Now, is it strictly just our COVID piece, or is it the African or whatever the?
No, it doesn't matter what it is. It doesn't matter what kind. It's just they took time off for COVID, even if that was just to go get a COVID vaccine or a COVID test, they technically could claim those hours and get paid those hours. So it's something that got pushed through the legislature really quickly and, created a nightmare for everybody. And like I said, I think we only had like 30 to 35 maybe that were impacted total.
We get paid.
You remember?
No.
Not even that many?
But we had some that were identified, but some were prior to December 31st, so they didn't qualify, but we still had to go back and verify for everybody.
Right.
So the ones that were affected, it was
more like maybe 20.
Yeah.
Okay, so 20,
23, something in somewhere.
I know when I talked to the CEOs at the other hospitals, they were just freaking out over this because this was, you got 2,000 employees.
Oh yeah.
Memorial and stuff like that.
Reimbursed for some of the time, the extra stuff, because it's not COVID related. It's not.
There was no money put into this.
Is Chet
He's there, but
I'm sure the employees appreciated it.
Yeah,
they did. Yeah, as a matter of fact, some of them, that's how we kind of knew that was showing up in their account because they were coming back and asking Heidi and stuff. Others, what are these hours, So, and like those hours will be out there at least through September 30th if they haven't used them. If they don't use them, then they go away, I think, at that point in time. So then again, we're rebudgeting. After our meeting a month ago, we decided, Chet and I decided we were going to go back and kind of relook at our budget forecast for volumes, primarily because, again, the normal process we use is we go back, we take last year, we annualize it, and then we pick up the prior 3 years and look at our trend over that time to figure out what this year's is going to be. Well, again, because this last year was such an aberrant year because of COVID and obviously having to close our outpatient services and those kinds of things, we decided to go back and just look at the 1 year, this last year, and literally do a zero-based budget based upon our volumes this last year. And then obviously we'll build up because we don't know how long it will take us to get back to normal. If we ever get back to normal from those things. And so this way we figured we'd start with this, and obviously as we get into our strategic planning and adding new services and those kinds of things, that will help us get back to those points and so forth. But anyway, so we did that. Chet's has reviewed those. I don't know if those have actually come back to the board to take a look at yet or not, but we should at some point make sure they get back here so you can see what we did. And he can talk about, I know he's got some budget things to review tonight. Then happy to put out that Curtin Health Systems has put out a provider grant program for 2021-22. They're making available $10 million for providers to apply for. The bulk of that, 80% of that goes to the safety net providers, which is Kern Medical, Clinical Sierra Vista, and Omni Health. the 2 million of that is carved out for the other providers. And it's primarily geared towards, there's like 5 or 6 different things that you can use the monies for. One is access to care. So in other words, if you want to find new ways for people to get into your services and those kinds of things, they talked about medical service area expansion. So you're looking at increasing your hours or the days that you're going to be providing care, which provides greater access to their patients. Clinic and hospital infrastructure issues, homebound primary services, primary care services. They're also looking at providing funds for minor technology and medical equipment, data sharing, EMR system improvements, things like that. And then the biggest piece is CalAIM initiatives. And CalAIM is a program that California decided to implement. It has been done in a number of other states and has failed in all of those other states.
Is that right?
Yeah, but California is going great guns on this thing. And in essence, it's a program that's going to add things to the services that your Medi-Cal managed care plans have to provide in the way of services, one of which is housing for homeless patients or people who don't have homes. So we now have to begin thinking how the heck are we, as the health plan, going to be providing those kinds of things. They're looking at a whole host of other things that what they call social determinants of change and health and so forth. They're looking at services called in lieu of services. So in other words, if someone would normally have to be paid to go to do something else, but you decide you now can provide that service for them at home, then why should we pay for that? Because they're not utilizing the system to do that. And so they're trying to carve out funds from that to do other things. It's a nightmare. It's going to take them about 4 years to implement this thing. And like I said, every place else it's been done, it's failed. And but California can do it.
How long do we have to provide housing for homeless people?
We don't know yet. That's the trouble. That's the point is we're being told we've got to begin implementing this now. And yet the state doesn't even have answers to those questions.
Is it 2 days or an hour or 2 months?
I don't know because the state hasn't defined them yet. Yeah. And this is what, again, so Current Health Systems is putting this out there to begin getting people thinking about it, in anticipation of not knowing what the state is going to come up with, and so forth. And so at least they said, this is what we've chosen to do since there was no guidance from you. So they're encouraging the providers, to go out and put some plans together to take advantage of this. And obviously, like I said, we've gotten a fair amount of money from Current Health Systems for these programs before. And so, we wanted the team to sit down. We've got until the end of April to submit our application for that.
Could we build some apartments that could be used later for something? If homeless people went away. I mean,
homeless staff people. Yeah, I don't know. Like I said, we're waiting to see what they come up with. They really haven't defined it. So
empty hotels available.
And that's the whole point is you're asking the providers and all of the, statewide, all of the health plans to sit there and come up with these programs with no justification, no parameters on it whatsoever, So these are things, like I said, that the state is required to pay, and what the states are trying to do now is to push this off on the health plans and just say, you go figure it out. But yet then there's no additional money yet that's been identified at this point that's going to come through for health plans to do this. So
our share of homeless people, is it Bakersfield? Do they have, or other areas, do they have more than we do?
I don't know how that works I don't know if any of you know, on a capitated basis based upon what we've got up here compared to our population versus Bakersfield. I mean, they have certainly seen a huge influx throughout Kern County, and a lot of them coming from the LA area and so forth, people trying to get out of there and other places that, but I don't know. Yeah, I mean, I know they've just did census data on this stuff, but it's been hard trying to get your hands around the actual numbers of homeless. So anyway.
So who would be working on that? You said it's something by the end of April? I'll
be working on that probably with Greg and Chet and some others as well. We're going to be kind of sitting down and take a look at some things. Clearly, like I said, as we learn this again, some of this money is available for EMR system improvements. There may be some stuff that we can do, changes that we're looking to make to that program that we have with the computers, that we might be able to apply some of that grant money towards instead of using other hospital money for that. medical equipment and so forth. I know, again, obviously we're going through our capital budgeting process now. If there's things that we can include in there, we've got to go back and take a look at some of the detail of those to see whether that might help us. And obviously the access issues are going to be key. We've had some conversations internally about transportation issues here in the Valley for people getting to their appointments or those kinds of things. So I want to go back and look at that. And I've had some conversations with Current Health Systems about maybe them providing some money for us to buy a couple of vans. They actually provided money to Ridgecrest to buy 2 or 3 vans, and they paid for the drivers for those vans as well. So I've asked them to go back and relook at the numbers up here to see whether or not there's an opportunity for us to pick up some money to do that here to kind of help improve the access into our clinic services, the hospital, or wherever. So they've agreed to do that.
Yeah. You're going to be planning on that homeless, that situation. If we need more area, Scott Kissick owns that everything, all that big empty lot of it. I'm sure he would give us a slice of it.
Leho owns the piece right behind us.
Yeah, I'm talking about the big, right behind the finance,
right,
and all that.
Right.
Other than that Leho lot, I'm sure he'd slice off whatever we wanted if we needed some.
Like I said, I don't know how it's going to play out for us yet. Like I said, as we learn more, we will certainly, put in for whatever we can get our hands on. So
upon doing this, are we going to be taking into consideration that some of those homeless, that's their right, they choose to be homeless now. So I think that's something that we need to make sure. I mean, usually they're getting checks, they're getting food stamps, and they choose to live that way.
This has been
the big nightmare for the health plan, and looking at this primarily because their concern is this is not a business we've ever had anything to do with providing housing, and like I said, we're more in the line of providing services for homeless people, again, because many of them in fact do choose to live that way. They don't want to be in one place.
And because they don't have the money, I assume that the state picks up the tab for that to reimburse. They don't even reimburse the hospitals.
They have not mentioned anything yet about reimbursement for any of this stuff.
Okay.
So that's been the big thing that the health plan's struggling with. It's like, okay, well, how are we supposed to do all this? If you're not going to provide us
they'll find funding. We're moving toward that.
Yeah.
And it's just the way that is.
Yeah. Well, like I said, this has not worked anyplace else. So that's another big concern that we've got here with this whole thing. So, and I think it just may have taken on too much. You may see it get pared down, hopefully, as we move further into this. But so anyway, that's a big thing that we've been working on. Then the other things we've started is we had our beginning of our architectural review meetings with the department managers that are going to be impacted by the seismic retrofitting. This was really an effort to go back and meet with them on the floor configurations that have been identified and begin getting more detailed work, asking each of the managers now to come back with a lot of those data sheets that have to be literally created for every single room in the facility that are being impacted by the construction, so that we know what the footprints are for equipment. We know what the heat output is for equipment, so we know where the plugs and the power supplies and the cooling that are going to be needed for each of these areas, so those engineers can all design that into the building and so forth. So we've got to get on that, because again, that impacts so much of the plan development going forward from there in the drawing of the construction document. So that started. We've met with most of the departments that were impacted this week. We've got a series of other meetings coming up with them. The managers have been charged with putting those room data sheets together. And so we're kind of working on that and helping them out with some of those issues. So pharmacy today and some of their issues. So that's my report.
Thank you, Tim.
You're welcome.
Any questions for Tim? Okay.
Notice I didn't talk a whole lot about COVID. So I'm just trying to.
Oh, it's my turn.
Yeah, Mark's going to deal with that one.
All right, Mark, you're up. Chief Nursing Officer report.
So yeah, our latest audit for the COVID positivity rate in the community, actually in the ED, shows an obvious surge to almost 6% in January and December, with a subsequent decline in February and March to approximately 1%. Wow. We're looking at some very favorable numbers in April. The first 7 days I've been kind of studying this and looking at it. February and March, we saw about 35 to 40% of the patients who were checking into the ER had been tested for COVID, while the now in the first 7 days of April, only about 25% of those have been tested, with in fact the numbers of patients in the ER kind of rising, which is kind of, it's interesting. So I think that people are actually showing an interest in coming back to the ER and getting seen for things other than COVID related situations. So that's a positive trend. It's a very short trend, albeit, but I will say that I'm excited about seeing those numbers, and I look at them every day. So far, we've had 24 staff members who have tested positive at various times over the past 6 months, and there have been no more than 4 staff out at the very same time. So right now, we have one staff person out with a COVID-related issue. There are no staffing shortages related to the pandemic that we've seen at this time. You know, I could probably associate some staffing crises in the community and in California related to the COVID pandemic, but nothing locally. Community COVID testing reported 23 tests done today, which is extremely lower than weeks past. Last week we had 36. The week before that, over 50 or 60, I believe. So numbers are dropping. We're still committed through June 2021. So we're kind of concerned. We're going to continue to do it through June. But if we continue to see these numbers dropping, I don't know. We'll see what happens.
The county did indicate that they've seen drops throughout the county in their testing sites. So this is not unique to us.
On a different note, all staff who are required to attend our mandatory security training, that will resume in the months of May and June. So we'll get back to the hands-on security training that we have been lacking over the past 6 or 7 months. And that segues into the next comment. We continue to have security issues within the facility. And I get approached probably 3 times a week regarding the concerns about safety within the facility and how safe are the nursing staff. We frequently get disgruntled family members and patients who act out and are frustrated with our, whatever it may be, our visitation policy, our whatever. So in the CAPS committee, the Critical Access Hospital Patient Safety Committee meeting tomorrow morning, we'll be discussing more security issues within the facility and seeing what we can do about those. Other than that, I have no further comments. Any questions?
What's your expectation as a result coming out of that committee? Will there be recommendations for different procedures? Are you going to need to be purchasing things? Do we need an armed guard? I mean, what kind of things?
There has been discussions about having at least a uniformed security officer within the facility for peak hours. We've already discussed that in the last 3 meetings. We've gotten bids from people like Transwest. We've got a bid from another security company. Bob Easterday is looking into that. He's the security officer. So hopefully tomorrow he'll have some answers with some quotes about what it would cost to have at least an armed security, not armed, back up, just uniform security, at least at the entrance or the pre-screening area of the hospital. I would like to at least see something, whether it be our people who are trained and then uniformed or not. A uniform goes a long way. There are a lot of a lot of ERs in the community and abroad that are around the nation that have uniform security, and they have proven to be very effective in kind of de-escalating situations or not allowing them to escalate. So that's the focus that I have for at least tomorrow's meeting and the next few CAPS committee meetings. I just need support from the various entities.
And what are those? The various entities?
Oh, well, it's very expensive to have a security detail here. But it would be kind of expensive to have an issue where a nurse got beat up or got accosted or assaulted. So we have to take these into consideration and figure out where we want to go from there.
Okay, Mark, with the volunteer sheriff's department, I don't know that much about it, but if we use them as a vehicle and got volunteers to volunteer through them to help us, or it's just a thought, I don't know.
Well, I happen to have a friend who is a volunteer sheriff, and he works very frequently, but as you know, those are volunteers. They don't get paid.
But there's another organization there that maybe if they knew there was a need, there's people out there that might volunteer. We wouldn't have to start a system to do that.
Maybe so.
Through them and come to us.
We haven't looked at that, but we will look at that, Gene.
Thank you.
Good idea.
How often does the CAPS meeting meet, the committee?
Monthly.
Monthly. And is that an open meeting? Is that public?
We'll have a staff meeting, but
usually there are designated members, but anybody who wants to attend, absolutely come by, say hello.
And is that a Zoom or it's on the premises?
I have a Zoom meeting set up for my CAPS committee meetings. Yes.
Okay, perfect. And what time is that?
Do you want an invite?
I would love one.
All right. I will arrange that.
Thank you.
It's at 9 o'clock on tomorrow morning.
Yeah.
Perfect.
Yeah. If that's allowed, I'd like to sit in as well, Mark.
Sure.
Thank you.
So it's an important issue. I'm glad you're looking at it in terms of down the road, justifying changes in procedures that resources, hiring guards.
Well, the trouble that we've seen, I'm sorry, Ross, to interrupt, but the trouble that we've seen lately is that family members get disgruntled because they can't visit their loved ones. And it's a big deal.
Is that changing?
It is changing at this point, but we still have some problems in that area. I can show video footage of people getting angry and frustrated that they can't visit or can't come into the ER. So anyway, that will be discussed tomorrow again. Hopefully Bob Easterday will be there.
So I guess my take on it is at some point you're probably going to come back to the board with recommendations.
Sure.
And my heads up to you is I'm looking for definitive facts on what the threats are.
Okay.
I don't want to make a decision based on fear. I want to know what the black and white facts are.
I want to stay away from the emotion of it also, but at the same time, that is a heated discussion with the nursing staff every time I come in the morning. Hey, I had another situation, and they're emotional about it. So yeah, I have to make rational decisions, but we've been talking about this for the last 6 months and we haven't done anything about it. So,
well, I sure don't want to see anybody get hurt, but
none of us do.
I do want to make a rational decision. So thank you, Mark.
Amen. I'll have some more definitive data for you next time we meet.
Do you have any more to report?
That is the end of my report.
All right. Any other questions for Mark? Thank you, sir.
You bet.
Okay, our Chief Financial Officer report, Chet Beadle.
Yes, what I'd like to do is start with the how we're doing on an operational basis after 8 months into this fiscal year to date. And I'll start with admissions and discharges in the acute care section.
Are you on a particular page?
Section, I guess I should say.
Are you on a particular page, Chet?
I'm sorry?
Are you on a particular page in your report?
Yeah, 15.
Okay, thank
you. Of the packet.
Thank you.
Sure. I'm looking over at the right-hand side columns of this, mainly the year-to-date of 228-21 and then 228-20 from last year. So this takes into consideration some of our testing periods, and it compares a prior year where we didn't do as much. And I just kind of want to, it was interesting to me to see how that was comparing. So in the acute hospital, part of the hospital, the acute beds, for the 8 months, we've had admission discharges of 205, whereas in the prior year it was 219. So if you look at the 8 months, you're not going to see as much of a decline as we have seen in the last couple of 3 months. For swing beds, 33 year-to-date versus 28 in the prior year-to-date. Again, that was a little better than what I thought it would be, because we were very short on swing beds in the last couple of 3 months after we changed from doing some of that work for COVID patients, putting COVID patients in swing beds to no longer putting them in swing beds. So we've seen that come down, but the months where we were doing that earlier in this fiscal year have kept us slightly above last year's year-to-date. That shows the same way, except a little differently in patient days. Acute care days, 990, 946 last year. So the days in the acute side actually are a little higher. So, and we'll look at that as we go down to the next section. And the swing beds actually were down fairly substantially, even though we had 33 admissions, if you will, year to date. And the swing bed days actually after 8 months, 552. Last year, 724. Now let's see why. Next section is average length of stay. Our length of stay is up. That's why you see that difference in acute, 4.8 days versus 4.3 last year. So a little longer with our acute patients, still okay, still in the reasonable range. Swing bed, 16.7 year to date this year and 25.9 last year. That's a fair difference. And that's why you see the difference between the patient days of 724 and 552. Again, the 16.7 is a more rational, reasonable, let's say, commensurate with other hospitals. Your length of stay in swing beds usually is between 7 and 15 days. Ours is a little bit longer, and that's okay. Sometimes we have people that for rehab. But you see back last year, we had 25. Well, there's not, number one, there's not as many patients for rehab in swing beds. And we don't have as many patients as we did last year with COVID that are being put in there. We'll go down to long-term care. Long-term care and average daily census of residents, 49.5. Last year, 55.4. We really continue to hurt in our census in the long-term care. I guess there's a lot of reasons for that, and I won't go into speculation, but in my opinion, something different needs to be done. We're staying mostly in the green tier. We have had some days in the yellow tier because of staff with COVID exposure, but we've got to work on that particular item of admissions, marketing and admissions in long-term care. It's not the daily census is where they go in and out. So you can see, look at the discharges, 62 for this year to date average, or in total, I should say, and 24 last year. So the patients last year, the residents were staying there, surviving longer for whatever reason, and staying there longer. We've had a few against medical advice, but not that many. Most of them have actually just expired. We've just got to do a better job of replacing those patients because they're not going to stay there forever. It just doesn't work that way. Go down to the emergency room, and the total ER visits after 8 months, 3981. Last year, 4979. Major reductions in the last 2 months. We've had, truthfully, I did hear what Mark said about, we had one day, we used to run almost consistently right around 20 patients a day. We've had one day so far this month. Through today, that's been over 20. We had a 21 day. One day, everything else has been down from that. And many of the days in the last 2 months have been single digit days, where we don't even see more than 9 patients. Obviously, we can't control, we're not going to go out and beat the bushes for that, but that's one of the reasons that Tim was talking about the budget and how he felt like, and I agreed, that if we use the methodology of a 4-year average plus the year-to-date and used that as our basis, we were going to over budget inappropriately some of these areas. So I took a look at it. I actually, mostly the areas that I changed were med surge, where we're seeing the reductions, ER, where we're seeing the reductions, SNF, where we're seeing the reductions, and those particular services that are mainly associated with those and not of themselves, like dietary, for example. Many of the ancillary services I did not reduce because imaging, for example, most of their patients do not come from those areas except the CT and the ER. The diagnostic radiology, the ultrasound comes from referred out patients from our clinic or other doctors' offices, and those are staying up. Going on to our outpatient next section, which is actually our outpatient visits. Our outpatient visits, and these are referred outpatients, 10,988 after 8 months. Last year, 8,976. So we don't want to reduce the volume in the outpatient, referred outpatient area because it's a growth area for us. And that's what we want. If you go down to the clinic, primary care, 12,135. Last year, 11,522. Again, a growth area. Specialty, this is mostly the behavioral health, 2,359. Last year, 2,295. Obviously, we're not going to reduce those areas. They are growth areas. Inpatient surgery, 1 this year, 4 last year. We're not going to see many inpatient surgeries, and I don't anticipate that. It's not of a material nature anyway. Outpatient surgeries, 24 versus 20 in the prior year after 8 months. So we're at least staying up on our outpatient surgeries. Dr. Buxton is having his every other week work in there for surgeries, and that's staying relatively constant. So I did not reduce any areas there. Outpatient scopes, that's the endoscopies, the GI, 24 this year to date, 20, excuse me, that's a misnomer, 312 this year to date, Last year, 284. So again, I did not reduce the endoscopies. The outpatient surgeries as well. As I said, Dr. Buxton's doing his share this year. Retail pharmacy prescriptions, 26,269 this year, 28,274 last year. I do not believe, I will tell you, I did not reduce the pharmacy scripts. Those guys are trying to stay up. I think they have a chance to do that. We continue after the COVID to try to market that a little bit more and see if that doesn't work. The next item down, we're keeping separate now, which is the mobile van. We didn't have it last year. We have it this year. Most of the visits are vaccinations, COVID-19 vaccinations, or the COVID tests that were in that area. So 1,508 versus 0. Again, we want to see that move better, take it around. We've got some things going on to add some services for the schools. That I think is a growth area for us. But where we can virtually see that it's not being used in the current methodology, I think it has something to do with the virtual, the fact that doctors' offices now do many of their visits on a virtual basis. And so people don't find themselves having to run to the ER for something that should be done in a doctor's office. They can wait at home with their feet up on the table until the doctor's office calls them back for their time for their appointment. I think that has something to do with it in my mind.
Yeah, I have a question.
Yes.
On the clinic visits, the mobile van clinic visits.
Yes.
You know, the number, I think the high number there reflects the COVID-19 vaccinations. And so I don't know, in terms of budgeting for next year, we're not going to have that volume because the COVID vaccines are a one-time thing.
You're correct. And if you looked at the mobile clinic, it does. And most of those were happened in the month of March. The lion's share of the vaccines.
Right.
There may have been a few in February and prior, but most of those visits are not in this number. Okay, I think we're going to have some. Because also, yes.
Yeah, Greg was going to add to that. Hold on.
I just wanted to make a comment that when I did my volume projections for next year for the mobile clinic, it was based on what my predictions are for going into the schools. We just started our first school visit yesterday, so the next year's visits are much lower, but it's going to be something that starts slow and increases.
I agree, Greg. I noticed that you were putting that program in, and so I didn't want to cut you substantially. We actually took Greg's numbers, and we are using them for the budget. Exactly, on the mobile clinic.
Great, thank you.
Sure. Let's see. I'm now going to go to page 16, 17, yeah, 16. Okay. Now you can see, let me go past this because I want to do year to date today. Okay, page 17. You can see that after 8 months, we have done $75,703,100 in gross revenue. Last year, for 8 months, $75,891,627. So almost the same amount of inpatient, or excuse me, most of the same of gross revenue generated as last year. Now, what you have to consider there is there was, as of April or July 1st, there was a 7% price increase that is in the current fiscal year and was not in the last fiscal year. But if you look at the detail there, which is kind of interesting, the inpatient revenue side is actually above the budget. That's one of the better areas. We were a little higher than last year. Shown, we've had some downtime in the last couple of months, and it looks like it's going to stay in that ballpark. That could be a change. We'll have to wait and see. But actually, I did bring the inpatient down a little bit because of what we're seeing in the last couple 3 months. The clinic, you talked about the clinic. Well, actually, the revenue is higher, but it's a situation where I did not change that and took Greg's numbers. The outpatient revenue is actually under what it was last year, and I still didn't cut theirs because their volume is actually showing more. So it's some intensity of service that we have, plus some COVID-related items. So we're going to see how that comes into the picture, where their actual visits are greater, their actual revenue generated is less, and how that affects the whole thing. But initially, we did not modify those downward much, if at all.
Yeah, are we reflecting in the chat? Can I interrupt for a second? Yeah, where is the ED revenue coming in here? Is that going into outpatient? Is that where you've got it?
Yes, it is.
So that's probably where some of that increases come from.
That it's as much less as it is. The answer is yes, it is.
Okay, thank you.
The long-term care revenue, you can see that less than it was last year. Certainly less than the budget, $2 million less. That has to come down. I just don't have any confidence that because I've been waiting now for 5 or 6 years for us to get back into the throes of putting patients in there, and we don't. It just keeps going down. That's very bothersome, but it is a fact. The retail pharmacy, you can see we talked about those being down a little bit, but the actual revenue generated is up, and that's just the mix of prescriptions, the nature of that. So I will tell you that for the most part, I left the retail pharmacy scripts the way they were. You can see the deductions from revenue there. In total, that's all deductions, 73%. Last year, 73%, which is nice. That means we had prices go up 7%, and we did not lose reimbursement. And there's another question that will come up in this that I will explain some of that. But let's just move on here. So out of the total, we have 19, well, let's talk about one more thing. The other operating revenue is money that we actually believe can be put into the income statement, $393,000 versus $216,000 last year. So some of the money that's already been allocated for keeping that we can keep and not have to pay back. But when you look at your balance sheet, and it's not on this, but we talked about it at the finance meeting, you will see that I've broken out an area for that. And I say the supplemental, under restricted, the supplemental income that may have to be paid back versus debt that's in other. So it's a situation where when we can, we put it into the income statement. And I think at the end of the year, this year, we hope that's going to be a good thing. At this point in time, we do know that we're going to have to pay back the advance from Medicare. We requested that it be approved, but they're not approving anybody for that waiver at all, period. The HHS money, that's still open. I don't think anyone knows what's going to happen there. And so everybody's just waiting to see what happens. And I just talked to a meeting of the CFOs for district hospitals this morning. Most of them are not budgeting for that money to be greater in the next year's operating, if you will, operating revenue, not from patient care sources. They're holding it until there's actually, are not putting it in the budget at all until there is some kind of a decision or cash basis that they get the money and can keep it. Salaries and wages, you can see, is below our budget, but a little higher than last year. That's only because we put 4% in there for salaries and wages, and we've given out those through 8 months, those anniversary date change increases, and we've given out the range adjustment, the parity adjustments that happened in December. Bridge benefits, you can see those are up. We'll look in just a little while, but you'll see that the percentage is not something that I am concerned about. It's reasonable within the national and state standards. Contract labor is actually down slightly on an 8-month basis than it was last year. 888,000 last year, 667 this year. The physician fees are up 2,408,000 versus 2,003,000, although you can see that our budget's 2,005,000. And that's because the lion's share of our physician fees are not related to their productivity. They get the fixed fee for just being available, if you will. Guys in the ER, just because they're effectively available, obviously they have to be available, but that's because of that. Even our hospitalist group, it's because they have a guarantee, no matter how many patients we have, either in the SNF and or in the medical surgical area. So that guarantee keeps their fees up. Purchase services, you can see those are fairly substantially up. We tend to have a large appetite for people from the outside doing things for us, especially in the area of IS, but otherwise as well. The majority of the increases are IS increases in programs. Supplies, you can see that's actually up some. I think that mostly is pharmaceuticals for the retail pharmacy. Utilities, you can see that's up a little bit, although we're supposed to save some money with that, the new lighting and other utilities. We're not seeing that happen. We knew that they were going to have about a 5% increase, and again, but utilization should affect it a little bit. It has not.
Hey, Chad,
repairs and maintenance.
Chad, this is
yes.
Yeah, on the utilities issues, Bob had gotten a report in talking with Train and some of the engineers and so forth, and what they noticed was that the electric companies and gas companies and everything else have increased their rates so dramatically that, you know, again, it didn't appear that we had much of any savings as a result of the light program and everything else. But when you go back and look at the actual electrical utilization, they saw a substantial drop in how much power we were actually drawing. So it did do what it was supposed to, but we can't control what they're charging us for it. So, and this is one of the reasons why the state was saying, hey, the CEC was saying, where's the savings that came from this program? They said, well, it's there from an energy consumption use, but not necessarily from a dollars for what it's costing us for that.
You're right, they're up in price. We knew they were going to be up a little bit. We put 5% in our budget. And it still wasn't enough. So just put that, you know, so it's greater than a 5% increase, if you will. Let's see. Insurance expense, you can see that that's slightly up, but not. They're also, because of all the things that have happened, wildfires, tremors, all those kinds of things eventually roll downhill. And so the insurance companies are at double-digit increases as well. Other expenses, you can see those are pretty much in par with the prior year. Leases and rentals, a little bit less. We don't have as many long-term leases now. Depreciation, you can see that slightly up, and it would be because we have added some capital expenditures. Go down below, investment income is actually less than what we thought it would be. Interest rates weren't as high as we anticipated for both the buyer side and the earner side. Property taxes, you can see are just about what they were last year. Long-term interest expense, just slightly less. Obviously, interest comes down a little bit as we pay bonds down. So that helped a little bit. You're going to see that go up substantially once we have started anything new that we're using as we start the construction project. It won't happen until the construction is done unless there are pieces of it that are done. And then pieces we are using will be depreciated or amortized. Other non-operating, again, this is money that we have coming through that we cannot take into operating income at this point, but we can take some of it into non-operating revenue. And so it's in effect deferred revenue or expense, and we don't know which yet. You can see that's up very substantially. $302,000 versus $45,000 in the prior year for 8 months. It doesn't mean it's actually all cash, but more just the earnings side of it. Okay, let's go down to cash for a minute.
Finance like businesses.
Okay, let's look at cash. I'm on page 21. Cash has continued to be very positive, and that's why I started breaking out on the balance sheet so you can see it. It might be wise if Heidi's there and you would like to see the balance sheet detail, that put the balance sheet and just the asset portion and the liability page, 2 other pages on there, so you can see a little more detail. But that's up to you, whether you want to see it or not. Cash receipts first. You can see how we started. We started with, I said we were going to have before the reserves in Western America Bank. We were going to have a negative 867. We only had a negative 487 in Western America Bank operating accounts. Okay, so we gained a little bit to start with, although both of those were negatives for the operation side. And if you look again at our income statement, we're actually losing about $400,000 for the year to date. After I went through and actually took even some of the purchase services related with Quest and put them in suspense accounts related to the county until the county had them contracted. Those will come back through on a monthly basis out of the suspense accounts over the next 3 months. But we're about 400 and some odd thousand, almost 500,000 loss. And so it comes very close to matching this on a cash basis. The cash receipts in the month of February were $6.7 million. What I had in the projections was $1.7 million. The $4 million you see in the miscellaneous cash, that was again money coming from either IGT or Prime combined, going to QIP, a lot of initials, and or HHS money. And so that's somewhat broken out, but how much of that money we get to keep at this point, I do not know yet. Salaries, you can see the salary disbursements. I said 985,000. It's been 1,055,000 in that month. Okay, so we didn't have 3 payrolls. This is simply rates plus premium time. Professional fees, actually, although we were up in expense for disbursements, we were not. Less than what I had anticipated, 280 versus 317. Supplies, again up, mostly related to pharmaceuticals, 339,000 versus 277 in that month. Other items, we had a lot of other items in the month of February. These are not professional fees, not supplies, but anything else that's in there, like the purchase services that we were just talking about, 840,000 payments, because one of the things that we seem to have to do with these IS programs, or especially if we're buying a service that's not going to be over time, is we have to pay for it up front. Well, thank goodness we have the money to do it right now, because it's actually $300,000 just in the month of February, more than what I had anticipated. And my anticipation is usually based upon the prior year. Construction, nothing that I could call construction in the month of February. The Cal mortgage loan, we were getting down to the portion where we're going to make that change that you'll see in part of March business, 23,000 versus 22. I had anticipated, because we were going to be enough in the hole before from operations, that I was going to take $500,000 out of LAIF. Obviously, with that $4 million coming in, I did not need to do that. So nothing was taken out, nothing was paid. I also thought we would be at the bond principal payment or an interest payment of $50,000. We'd already paid that. That's basically the line of credit for the most part. Although it says bond principal and interest, it was basically what we were going to pay on the line of credit. But something in the bond too, but we'd already paid that in advance earlier in this year. So the total payments were $2.5 million versus what I said was going to be $1.7 million. $1.7 million versus $2.5 million, and that puts us in a cash position, actual, of just over $3 million before any reserves that were not invested. 943,000 negative is what I thought we were going to be. The operating reserve actually was 145,000, which is about what I thought it would be. And it's called Medicare Overpayment Reserve. Well, it wasn't Medicare, but let's say advance and COVID money, if you want to say that, or supplemental money, 5.8 million. You're sitting in those accounts versus 773,000 is what I said it would be. So a lot of money's going in there. Some of it's restricted to until we know what we're going to have to pay back. Some of it is not. It's a combination. So where I thought we were going to have cash in the bank, actually at West America Bank for operations, a negative $24,000. We were actually at $9.7 million positive. So cash continues to be good. It just depends on what we do with it as we go forward, especially if we have to pay back some big funds. And that, I believe the Medicare advance starts being paid back in the month of April, but we have 11 months to pay it back. And that's my report.
All right, any questions for Chet?
Chet, on the IGT, do we have a reserve for that? In the past, when we didn't have any money, we would borrow it from West America, pay the interest. But now, shouldn't we have a reserve when we get the IGT in take what's ours and then put in the bank or reserve what we know we're going to be required to pay to match the funds? Or are we going to borrow it from the new bank?
Are we going to do what? Can I say that again?
The IGT matching funds.
Yes.
How are we going to, where's the money going to come from to match whenever we have to match it?
We actually have they wanted us to match $1.9 million this month. We didn't even have to go into our base fund. We had enough in that money that you saw there that we actually paid the $2 million, $1.9 million.
Okay, good.
For the cash we got.
That's not going to be required to be paid back that quickly. It is spread out over time. And so we'll have the money back plus a like amount before we ever have a concern about that. So it was paid out of the money in West America Bank.
Yeah,
I think that was done last week.
Yeah, cool. That's awesome, actually. But the PPP, I know I keep asking about it because it's doing 2.2 million.
Here's where everybody is on PPP. Everybody I know of has requested that it be forgiven. You know, they actually forgive that portion and don't ask for anything back. This is to the Small Business Administration. To do that, what everybody had to do was take the bank that they used and convince their credit committee that there was adequate proof of spending at least that much that they got on the COVID-related items, that they could keep what they had. Most of the hospitals have gotten by the credit committees of the hospitals, or the banks have gotten by the credit committees of the banks. And the banks have forwarded that onto the Small Business Administration. The Small Business Administration has not given one peep. They have not approved anybody. They've not partially approved anybody. And as far as I know, they have not denied anybody.
Okay, Jeremy.
So that's where we are on PPP money.
Okay,
Whether it
Jeremiah.
be partial, a whole, or none at all, I think eventually will be by individual hospital. But there, as far as how is the trend's going to go, it's totally silent right now.
Cool, that's good. Jeremiah, our normal contact, I think, is no longer with West America.
Right, we just heard that. Yeah.
All right.
Yeah, everybody's watching. Let me tell you. But that's all the hospitals. The ones I'm associated with at all are all waiting to hear on that, and nobody's heard anything.
Cool,
Matter of fact, all the district hospitals, we've talked about it. We've asked about it to the.
That might be something we want to go to Kevin McCarthy
leadership forum. Nobody knows.
He can't.
The ones that are in the
federal issue.
California Hospital Association, with the legislature, again, PPP money is the Small Business Administration. They don't know. So that's what I can tell you about PPP.
Thank you, Judd.
Yep. I think basically the only other thing I want to say is page 23, which is some of the things that we have to have in the right now for the bonds, the old revenue bonds. This will be the last month you see it in this particular bonds. They're gone as of the 23rd of March. They have no capital replacement requirement. We did last with the old bonds. We had a base plus 4% increase per year. So you can see that in this particular fiscal year, through the 8 months, we have a requirement by year end to spend $538,000. We've actually spent $469,000. So we have $69,000 to go to meet our criteria. So basically, all those things are going to be out because that's funded on the side. they will be, we're actually done with that as of March.
Right.
The next piece down, what you will see is you will see relatively close to the same amount of total requirement. See the total requirement there of the bond reserve? There is no bond reserve in the new bonds. That's how good that is. From $1.5 million that we actually had reserved, what they do is usually require you to borrow 1 year principal and interest, which we did. The entire amount was spent in 1999 because they made no bond payments. So they were trying to get us at so much per month to kind of get that back up. They're giving us a buy on it for a period of time because of the agreement with Cal Mortgage. That's gone away as well, so no bond reserve. The current funding toward payment. As far as I know, the first payment will be September. It's next September, okay? So the September payment should be on there with the interest and principal in total, and then the following 6 months amount on there. So Robert's working on that with the auditors. Then we'll have a cash flow by month that will be there for the new bonds. So 23 will be there, but different.
Thanks, Chet.
I hope that's my end of my report now.
Yeah, that's great. Let's move on our agenda unless there's other questions for Chet.
Well, one quick, I don't know if this is the place, but our aging over 60, maybe I'll put it off till later. Oh, never mind.
Okay, so that brings us to item F, old business. And the first item is the fiscal year 2022 budget assumptions. And Chet, we turn back to you for that.
Okay. Where I am on that, obviously we went over some of the assumptions Barbara did at the last meeting. We actually, I guess, got stuck a little bit on a couple of things. The first item, Tim and I somewhat explained, we weren't stuck on it, but Tim was dissatisfied about, thought we were over budgeting on some of our volumes. So we moved some of those down in areas where we've seen some reductions. And that's how we dealt with that. And basically we've moved along. And so that was gonna be accepted. What we actually got, Tim sent out to all the managers, the original, the board had volumes in their areas that the board had approved. And then I just actually went over that so you can see what was approved and what I was saying I would like to see or believed would be correct. I had absolutely zero of those that came back and said, oh no, we're gonna have more than that, with the exception of Greg. And we took Greg's projections 100% from Greg. I had some, I did warn Tim and I warned some of the departments that when we take these down, the rest of the budget's gonna flow because they're based upon volumes. So they're gonna see things happen on the expense side as well as the revenue side when we do this. It just doesn't work any other way. You don't say, gee, that's okay, all my expenses are gonna stay the same, but I'm gonna take my volume down, my revenue down. Well, it doesn't work that way. And I kind of let Tim know about that to start with, and he said he was still okay with using the reductions. So we're in the throes of that already, of how we're dealing with the expense side.
So I have a question regarding the budgeting. Is this an actual reduction in force, or is this reduction by attrition, or how are we going to implement this?
That's not up to me. That's up to Tim and the approval of the board. Okay, how it happens.
Yeah, the bottom line is, like I said, we can't continue.
I do not make that decision.
Yeah, we can't continue to obviously see our volume down and then figure out we're going to spend the money like we had the people there. And I just said that doesn't make any sense. So, I mean, obviously we are going to have to make some adjustments. Obviously, if the numbers come back, then the staff come back as well, because so we have to staff, the whole point is to staff the volume. And some of the departments will get hit by that. And we'll have to sit down and look at that on a case-by-case basis as to, how deeply we have to cut on those. So
when we're considering budgeting, though, you're talking about cutting people now, not based on.
No, we're letting the people know what it shows. All that's happened, Barbara has used.
People aren't going to stay with us if they get their hours cut.
Bottom line, this doesn't take effect until July 1st, Mark.
That is not correct. Barbara has actually put out a new projection for, just recently, for the FTEs. That didn't go to the Personnel and Policy Committee this month because it wasn't yet available. I asked Heidi about that. That goes to the board P&P on the next monthly meeting that we have. And all it does is show what the departments are, if you will, versus what projection is there based upon the new volumes. That's as simple as it is. And I believe that the managers got some of that. You remember, Heidi, whether that got to the managers?
I don't know if the FTEs. I've seen a couple of them go out. I'm not sure what the latest version was.
Let's take a look at that tomorrow. Yeah.
Mm-hmm.
There are some that cannot function with the recommendations that you have provided, Chet.
Mark and Chet, you guys need to have that discussion offline. It doesn't need to be at the board meeting.
Thank you.
I'm sorry, say that again.
That discussion between you and Mark doesn't need to occur during the board meeting. You guys can have that offline.
I agree.
And Mark, I'm glad you're speaking up. If you think the assumptions are wrong, then definitely get that corrected internally.
I've tried to have these conversations before. It falls on deaf ears.
One of the things, if I can, like the pharmacy, the mail order is eating our lunch. We need to be able to get our share, and we need to step up a little. I'm always talking about the pharmacy, Tim. Sorry about that, but we can make it better and make it where they'll use us. We're going to keep losing share.
This last month we had 3,600 over prescriptions down there they filled and stuff like that, which is considerably higher than we did the month before. So yeah, so they're working.
And BFMC and that with the urgent care, they're scratching and taking our money.
Yeah,
we have to compete.
Yeah, I agree.
I'm sorry if I got in the middle of where I should be.
Nope, you're good. It's not a problem.
So clarify something for me, Tim. With these budget assumptions, I mean, we'll adopt a budget and that will be our target, our goal, what we think we're going to earn in revenue and what we think we're going to spend on our expense side. But the reality is the reality. If more money comes in, if the volumes go up, then we increase staff accordingly, correct?
Correct.
That is correct.
So the only thing that we're talking about here is what the budget states. But if we have the volumes, if we have the nursing staff that is needed, then those hours will be there, correct?
Yes.
That's a big if.
How else to do it, Mark?
Well, I mean, the fact is that once you establish a number, people go elsewhere when they get cut so many times that they don't have any more PTO to use. They're going to go.
We haven't cut people here in a long time. That's the reality. We're asking people to manage and stuff like this. So we're talking about a budget. So I haven't been available. I haven't seen the new numbers myself. So let's sit down and go through those and show me what you're talking about. I know you brought up an issue with me.
Just so you know,
today, with regards to dietary, show me the numbers.
Reduction in force, 2001. The last reduction, of course, was 2001.
Right. So.
Okay. Chet, do you have more comments on the budget assumptions?
I hope not, unless you would like me to.
I know this has been in the board packet. Do any of the board members have questions for Chet or Tim on the budget assumptions?
Yeah, it's probably, we can't do anything but do better than what the budget says. I mean, unless we close the doors completely. You know, we should adopt it the way they want. However, I could even do better than what the budget says, I think. But at any rate, I'll make a motion, we approve it if you need discussion or whatever.
Well, I'd like to make a comment before we do that, but I think one of the things we need to focus on, maybe two different things, but getting the monies in. Skilled nursing, pharmacy, we need to take action so we can get the monies in to keep the staff and stay positive about it, see what needs to be done and work on that. Because I agree, if we cut people, there's always jobs somewhere else. I mean, I watched when, you know, LVNs went to Dollar General. So, and I don't want to see that happen, but I think we can focus on, in our budget and stuff, things that we can enhance to get the monies in to keep that budget where it needs to be or increase it so we can increase our numbers. Skilled nursing is a big one. You know, we're not even meeting what used to be, I think, the goals to even break even.
There are no CNAs available. Once I mean, we've been looking and looking and looking. I don't know what else to say about that. We're doing a class. We're graduating 9 CNAs in May. I mean, I don't know what else to say about that. You can only admit so many and keep yourself within the guidelines that CDPH has put out as far as hours per patient day.
But so in May, we will have 9 CNAs that will be ready to go.
If we're successful in holding on to them, you know.
So we need to have a plan in place to have those beds people being admitted so they have a place to work.
Agreed.
So I think we need to focus on the positive of how we're going to make it work instead of what the negative is, because otherwise we're not going to make progress. I don't think. I think we could sit here and talk about the same numbers that we talked about last month, and we'll talk again about them next month. But what is going to be the change? I think there needs to be a plan, not just a budget, but a plan of how we're going to fix that. And that's all of us, not just, you know, that's why I asked about the CAPS committee and different things, because I'm sure there's things in there. I mean, I'm looking at bills that off of credit cards, and most of them have a $49 late fee every month, $39 late fee every month. I don't know what the reason is for that, but that's money that we're spending the wrong direction. So I think we need to stay positive about it and work on what we can do. That's just my comment on all this. I appreciate all the time that goes in on all these numbers. And I sit here and I listen to them, and I see the joy that it brings Chet to talk about these numbers. I wish I had that joy with you. But I know you need to do it. But I think there's places we need to look at how to put money back in, not to spend it out unnecessarily. So, okay, I'm done.
No, that's not the place that I talked about the 90 days in arrears. I can do that later.
So Tim, with it.
Right.
Hey Tim.
Yes.
With the skilled nursing facility census, you know, we were under the impression last year that or a couple of, you know, this has been going on a couple of years, that the reason the census was down was because of the shortage of CNAs. And so we've increased pay for CNAs. We've made offers to CNAs, increasing compensation as an incentive. We've developed the training program for CNAs. So we've graduated 1 or 2 classes now. But the census doesn't go up. And so what is the factor that's keeping us from increasing the patients in the skilled nursing facility?
Well, again,
COVID?
COVID had a huge impact. There's no question about it. And, like I said, we have just recently beginning to see more referrals coming into the department. But like Mark brought up, he says, we're at a point right now where we're having great difficulty even getting a CNA. And like I said, oftentimes what we're having to do is we use a recruiter or a traveler that's paying huge amount of money to get a CNA in here. We talked about, Mark just shared with me a situation this morning where we had a staff member who was going through the last training class that we did for CNAs. She's now working at, where is it, Mark?
Taco Bell.
Okay. And making as much money as she would have made here, So, because they're probably making $15 an hour because they've raised their minimums and stuff like this. And our $15 threshold isn't going to hit till next year, until January. So, again, this is why we're trying to come up with some plans to try and beef that up a bit, to try and get ahead of that curve. Because hopefully this next January will be the last we see of these mandated $1 an hour increases that are hitting us. But, the point is we've got to continue to pay competitive wages, or we're going to be in a constant training mode. It's just the way it is. It's in everybody. It's not just us. So.
The unemployment, the $450 extra a week or whatever it is. It's that September is when that's over, unless something else happens.
Yeah.
Will that help us?
The kids don't have a vision of using a CNA as a stepping stone to an LVN to an RN. They just see the immediate whatever they're getting, and they don't want to be a CNA. They don't think that it's worth it. I feel I'm seeing a lot of that by attrition. People just don't want to use it as a stepping stone to become nurses. And I think that's not just here, it's all across the.
No, he's right. And like I said, when we have our new employee orientations, Mark and I go in and we talk with the staff, especially the CNAs, and tell them that, again, you got a great career ladder opportunity here, obviously because of the CNA program and the LVN training program and those kinds of things, where they can earn really, really good salaries. Matter of fact, I was just reading a report this morning. I've got a copy of it on my desk that lists state by state the average pay for RNs. California was number 1. The average pay for RNs annual pay is $120,000 versus many of the other states that are down $60,000 to $65,000, $70,000. It's just because how much more they get.
We just need to pay more. We need to do what we need to do.
Yeah.
We can't keep saying, well, we can't do it.
But here's the trouble you get into. Like I said, and again, there is some limitation on being able to respond to that, because like I said, fine, we can certainly increase the raises, but we're not getting significantly more money out of Medi-Cal to pay for those services and stuff like that.
But if we get our business back up, we'll have enough money, it'll be nothing.
Sure. Well, right.
And do we have...
And hopefully, like I said, we can graduate some of these, we won't be paying that expensive dollars to registry people.
In September, there might be a line outside the door wanting to be CFA.
Hopefully.
Well, I think to Catherine's point, pre-COVID, I know we had started to work on a plan to increase the census in the SNP.
Right.
And all that went to hell in a handbasket when COVID hit, because nobody wanted to put their loved ones in a nursing home. So I think when we come back to like the strategic planning initiative, what can we do to get that into the public where they don't have that fear of admitting their loved ones?
I think, as I said, it's beginning to change. We had seen that, again, and then the other issue, you've got patients, like I said, who do expire.
That's true.
Again, it's in a long-term care facility. And so, it's staying ahead of that curve, there's a big aspect of that from a marketing perspective.
They do expire, but I've seen some here 15 years
Oh,
or
absolutely.
longer.
Absolutely.
I mean, this is their home.
Right.
And so they can, you know, be here 15, 20 years, especially when they're admitted at younger ages because of other things that are needed to be, you know, cared for.
Right.
Whether it be mental health or, you know, it's going to be a lot of different things, but it's not just the public. We need to let other facilities know. We need to let other hospitals know that, hey, we have a bed. We have 3 females, we have 4 males. You know, send us some information and let us look at it. And then it's going to have to be more than just 1 or 2 people looking at it. It needs to be looking at it from all aspects and say, you know, you don't want someone saying, well, we can't do that. They have a behavior problem. Or we can't do that because they have. Well, you know what? We're licensed as a skilled nursing facility, and either we're trained to meet those needs or we're not. And we need to decide what it is, you know. I think we have the capacity to do it.
Yeah, it's got to be managed. Yeah, right. So we have to manage it. And we can do it. Yeah.
It can be done. Absolutely, it can be done. You just, everybody needs to be, I don't want to say on board, but they need to be willing and to put the effort in to let others know. I mean, other facilities are big ones. Yeah. You know, there's people that have been on the list or have previously that I know that are in other facilities and have wanted to come here, but they're told that there's no beds available, which in any hospital or anything, it usually goes to there's no staff, you know, because it's hard. But I think it can be done. It just needs to be something that's put in a plan and looked at strategically and go forward with it. And if another, you know, fire hits or another COVID, we stay focused on letting people know we have, you know, that we have a bed available and that we're willing to care for their loved ones. So, and that's what the skilled nursing's been about since it was built. So
Tim, at the governance meeting next month, or well, the end of this month, can you refresh where we are with the strategies for the skilled nursing facility from our strategic plan?
Sure.
Going to bring us up to speed on where we are with implementation?
Be happy to.
Thank you. That way we can report to the full board at next month's meeting on where that is, because it's not something we've ignored. We're addressing this. We do have a plan, but COVID really messed up our implementation. So, but I don't know all the details. I'd like to see where we are. So Jean made a motion to approve the budget assumptions. Is there a second? No seconds.
I'll make the second too.
Then I'll speak up at once.
I'll make a second. Or did you already do it?
No, Catherine, we need one. Thank you.
Okay, I'll make a second.
Is there any more discussion on it? Does any member of the public wish to be heard on the budget assumptions? Okay, then we'll do a roll call vote on this. John?
Abstain for now.
All right. Jean?
Yes.
Fred?
Ross, I'll be honest, I need to abstain at this time. I'm just a little uncomfortable with some things and I need to clarify.
All right. Catherine?
I'm going to say yes. We have to start somewhere. Yes.
That's kind of where I am. Budgets aren't cast in stone. And if we make some incorrect assumptions along the way, then we correct them as we go. So I'm a yes vote on this.
I just want to clarify, I'm not being negative. I'm just.
Good job. No, I get it.
That's just a little clarification. That's all. That's all.
I get it. And I'm definitely okay with that.
Okay, item number 2 under old business, employee bonuses. And Tim, you share some information on this?
Yeah, and I may defer to Scott here. was brought up at several of the meetings, board meetings last month with regards to, is there some possible way that we can find a way to pay the employees some kind of a bonus or do something for the staff because of everything that we've all had to go through because of COVID and the difficulties and so forth. And so I had asked Scott to go back and research this from a perspective of public law and so forth. And so, Scott, do you want to share your findings?
Yeah, so public employment law is different than private sector employment. And public employment law tracks the law regarding public agencies and contracting in the sense that when you make an agreement with a public agency, you are bound to that agreement. So essentially what the law is on an employee's anniversary date, when they agree to the compensation package, that the agency is offering them, whatever type of agency it is, hospital, city, county, airport, water district, that for the next year, that is their compensation. And so in this case, the question was, could the district retroactively look at paying bonuses? And the law in California is no, that you cannot do that. So I laid out the kind of the legal framework for that in the memo that's in your board packet. If there are any questions about that, I'm happy to answer those questions. But this is just an area of public employment law that is probably different from what most people are used to in the private sector, where you have a lot of flexibility with your employees. And that's just not the case with public employment.
We give them a bonus to stay.
So you can give incentive bonuses. You need to have a program in place to, you need some basis for awarding it. But yes, you can. Sometimes they're called stay put bonuses or incentive bonuses, but you can offer those, yes.
We look at that, Tim, or even at the worst case scenario, a gift card at Paradise Cove or somewhere for $100, or I mean something.
No, that I would have to definitely abstain from.
But I mean, would that be? Well, I guess that's up to the what is it? Which department does that? You guys could look at it.
Yeah. Okay. Yeah, I mean, I think there are small things we can do on a small basis. And like I said, we're working on one right now because we've got hospital week coming up, and one of the things we were looking at doing was having nice embroidered polo shirts done for the employees, primarily because of that. And so, it was more than we normally would spend. And as the staff reminded us, the fact is we used to do an employee picnic out in the front lawn.
Oh, that's right.
And so forth, but because of COVID, and we haven't actually done it for a couple of years now for various reasons. So we just said, fine, that money's always been in the budget because it just kind of rolled over. So we just said, fine, well, maybe if we take the money from both of those, then we can apply
we
it to
got
something
so
nice.
much extra money because of that COVID, and they deserve a little bit. They deserve it.
Like I said, we'll figure out something that we can do.
Yeah. Some of them you don't want to stay put. Maybe you can't do it because you want some of them to not stay put.
No,
I couldn't imagine any of them.
No, nothing to do with that.
Okay, all right. Then
I always appreciate doing something for the employees, where we can.
So we understand, but we're going to move forward, maybe a stay put or something like that.
We'll see we'll take a look at some different options, and we can certainly bring them back.
Cool. Thank you.
Thank you, Scott.
Any questions of Tim or Scott?
I have a different question, not related to that bonus thing that he's addressing. Can I ask him just a lawyer question?
Does it relate to the agenda item?
Okay, it's not. I'm going to do that at the
Trying to get some free legal advice.
You're going to get some carte blanche here in just a few minutes.
Okay, thank you. Sorry, I get confused so dang easy.
Okay, item G, new business. This is the fiscal year 2022 capital budget.
That's mine, I guess. Page 67, which is the last page of the packet, has the summary proposed capital budget for 2022. We sent out notices early in the process to all of the managers for them to create a list that they would like to see purchased during the next 12 months, beginning in July of 21. And this is what we got back, even though we waited even an extra week. It's 521,000, but there's one very large item, which is the chemistry and the assay analyzers in the lab. Now, as far as I know, there's nothing wrong with the chemistry and immunoassay excuse me, analyzers that exist now. However, it's pretty much a standard in the laboratory, not just ours, all laboratories. They like to see the latest technology, sometimes even before the useful life is ended. I don't know exactly the useful life of where we are, but our lab equipment and its usage is not something that's extraordinary, high, or low. It's kind of in the middle. And so we accepted their request in finance, and we put it on here, but I put it on here as priority 3, which means to me that if something goes wrong with it, we move the priority up. If something doesn't go wrong with it, we leave it unless we really need to do something differently. And let me say what I mean by something differently. If the doctors aren't liking some of our results, or they believe that there should be a better technology, then we take a look at it. So that's kind of where that is.
Hey,
yes.
Chet, this is Ross. I had more questions about.
We lost you there, Ross.
Uh-oh.
Yeah, you're back now.
Am I here? Hear me? Okay. I have more questions about the capital budget process. By the board approving this document and these items, I don't know what that means. I don't know that we're going to go out and buy these in the next budget, or that they still have to go through an evaluation. Because, you know, when we have to
go through the evaluation, Ross.
What's that?
OSHPD requires that we have a capital budget. Actually, they'd like to see a 3-year capital budget available.
Yeah, let me finish. Hey, Chet. Hey, Chet.
The packet explains all of that.
Hey, Chet! Hold on. I hadn't finished asking my question.
Oh, I'm sorry.
We do an evaluation of capital expenses almost every month. Is that level of detail going to occur for each of these purchases, or is approving this tonight the only time we're going to see it?
No, that's out. This is just the beginnings of that. When they want something, they have to fill out a capital equipment request.
This is nothing but a plan. The individual requests still have to come before each of the committees to get approved.
So there'll be a more thorough evaluation with each item?
Definitely.
All right, terrific. That's what I needed to know. Thank you.
I'm still waiting on some quotes for some items that I wasn't able to get into this.
When we get a completed capital equipment request from a department, which is what it takes, and this is all explained in their packet, Ross, that's what I was trying to say. Let's say that the person, and I'll just pick that one I had in the laboratory. Let's say that our laboratory manager felt like it was time for her to put something through. She would fill out, if she called and asked about it, she'd say, well, it's on the board approved budget. I would say that's just the preliminary for them to have an idea of what you wanted, or the auditors or the state to have an idea of what you wanted. You must fill out a capital equipment request. That's where the detail comes. You've got a couple of them in your packet tonight on those beds that you approved in a consent agenda that Mark talked about. Those are the kinds of levels of detail with quotes. and with actually at least 3 bids before anything is ever approved. And before they even come to a committee, Tim has to approve them, and normally I have to approve. That's the way it works.
Great. That's what I needed to know. Thank you so much. Yep. Any other questions or comments on the capital budget?
I'll make a motion, we approve it.
Thank you, Gene.
I'll second.
And John seconds. Are there any members of the public that want to be heard on this matter? Okay, any board members have any further comments? Okay, then I'll do a roll call vote. Catherine?
Yes.
Gene?
Yes.
Fred?
Yes.
John?
Yes.
I'm a yes. So that brings us to item H for director's comments. And we'll just start with Gene.
Is there a time limit?
No, go for it.
Okay.
Hey, don't say that.
Okay. Scott, it's just a question on procedure. It's not, if we're under a contract and it's over $25,000 a year and the contract expires and it goes on month to month, it should be on a month to month on a contract because it's renewing every month. And we've got a situation, and I'm not going to go into anything other than what shouldn't it be on renewing every month if it's monthly? Shouldn't it be in the picture somewhere? Because this has been off the radar, out of the picture. And what's the remedy? What do we do? Do we fire somebody?
Well, it depends on what the contract says. Most contracts do not have month-to-month renewals. Month-to-month renewals is a real property concept.
Okay, let me get specific. I'm sorry, I don't want to cut you up, but it's getting late. I'll just get specific, okay? Back whenever propane contract came up 5 years ago or whatever it was, apparently there was a contract with AmeriGas. And when it ran out, we just kept ordering from them without any contract and without any documentation. I kept waiting to see the contract come up and it didn't. And so it's not a big deal other than procedure. What do we do to get it to come up? Should it have been on a renewal? I'm not saying.
My understanding, it typically converts to it.
So it's ongoing monthly
thing. So like I said, once the contract's expired, because normally they do the contract because you're paying for the tank they put in or whatever and so forth. So we're actually looking at now. I mean, the issue is the contract we had for this has been so long ago, nobody has a copy.
I can tell you the cost should be about $1.25 and it's been closer to $2. So
not for the big tank, it isn't. For the little tanks, no, I've got the numbers on my desk.
I know.
You can look at them afterwards.
Okay.
They're averaging between $1.25 and $1.95 was the highest I saw per gallon on that tank. Okay. So I have them on my desk.
Okay, but we're getting quotes and everything.
Yes.
Okay.
Yes.
But how does that slip through the cracks? I mean, who
that contract's going to be in place probably longer than I've been here. So
yeah.
I don't know when we entered into that agreement.
Okay.
So I mean, like I said, we're trying to get our hands on that, and it just doesn't seem to exist.
Okay. But under normal conditions, what do you do? I mean, isn't there a?
Yeah, Gene. So generally, when you look at the consent calendar, and we can talk probably with Heidi and Barbara about this offline, but you have contract renewals that you approve. And I believe that based off your contract list, that if it requires an annual renewal, or if the contract naturally expires, but you keep using the vendor, that on its anniversary date or thereabouts, it comes up on the consent agenda for the board to re-up that contract. So I would imagine, because your hospital is very good about tracking your contracts and making sure that they are brought to the board on a regular basis per the terms of the contract. So we can probably go back and look and see the last time that was on the agenda. And I don't know if anyone there knows off the top of their heads, but you guys do a really good job, probably the best of all my clients, tracking your contracts. So I would not be surprised if it's approved every year.
Yeah, well, it's that specifically, I'm not so concerned about is the procedure. What do we do? I'm not comfortable. Are there more things out there that we're doing that we should, we're not doing that we should be, if that has slipped through the cracks? Is there a safety net, or how do?
I wonder if I can do my input here, even though I said I wasn't going to. Are utilities different? I mean, we don't have an annual contract with Edison, do we?
You don't have a choice. You've got to pay Edison.
Well, right, but I mean, so it's month to month. We pay what the bill is. So, I mean,
but who do you buy it from?
Right. No, and I get that. That's what I'm saying. Are utilities different, or is it just because there's more different businesses that we should be?
Yeah, we can get bids. We can't get bids from Edison.
Right.
Yeah, there's some.
Okay. So that's I was just asking because I know not everything would be like utilities. I didn't know if they were different. Only just, I guess, because there's more than one vendor in town. Okay.
So Gene, if that contract has expired and the board would like to take it out for bid, that is certainly something that can be done.
We're actually doing it. I mean, on this one, primarily because Gene brought it up with regards to what and we switched to one of the other vendors for the clinic and for one of our other properties at a significantly reduced price. And so, but like I said, we had to go back and re-verify whether or not we actually had a contract in place on this one. And if not, we don't. And so Bob is actually out now getting bids from the other local vendors to bring them back to Finance Committee.
We'll probably save enough to buy a gift certificates from Paradise Golf for everybody.
I hope you're right.
The other thing, if I could.
Yeah.
Scott, I've asked you before, and I'm not saying that you didn't listen to me. However, the earthquake requirement, we keep talking, we got to be compliant. I have never seen anything that said, the only thing I've seen is it says hospitals built after 1973. We were built in 67. Are we really required? Now, I'm not saying we don't need to do an addition or whatever, but are we required to do it?
Yes, you are required to do it. You are, if you do not meet the current seismic requirements, then you have to replace or retrofit.
Okay, and the document I saw said that was true for hospitals built after 73. Again, we were built in 67.
So it would apply more to hospitals pre-73 than post-73. After Silmar, the state updated the seismic requirements for hospitals and schools. So if you were built after the Silmar quake, you probably stand a better chance of meeting the current seismic requirements than if you were built before.
Which we did with our SNF and the other construction that we did.
Okay, so you think definitely we fall in a have-to situation, because I couldn't find anything that fit us that said we have to.
It applies to all hospitals. There aren't any exceptions. There are seismic standards all hospitals have to meet.
What about one that's run by Tim?
That is an exception.
Especially.
Okay. All right.
Run by Tim, and Gene is on the board.
Okay. The only other question I got, and I'll make it real quick. In our paying our bills, if we've got some that we can put off paying and not pay them because we don't have to pay interest or penalty, is that a prudent thing for us to do?
Well, let me tell you, I'm sure Chet and Barbara have an opinion on this, but you know, when I started working with you guys, you had a lot of vendors who were COD. They were way behind. You had vendors who would not work with you because you weren't making payments. And as a responsible member of the business community there in Kern River Valley, it probably makes sense for you guys to make your payments on time.
Okay.
And in many cases, you also have a contractual obligation to make your payments on time.
Well, to give you an example, right now we're $383,000 over 60 days. And some of them are basically almost forever that we owe. Shouldn't we make an effort to pay them? Right now we got the money. It would be a prudent and a good thing to pay our bills.
I don't know about the particular vendors who you may be over 60 days on.
Yeah,
we would have to look at them on a case-by-case basis and figure that out. Tim and I have had conversations about certain vendors in the past. Talked with Chet about it as well. And, I don't have any complaints about how they manage the money, but, on a vendor by vendor basis, you should look at that. I would say.
Okay. And there's things to be paid in here, like a guy named Working. There's no invoices. There's no reason why he's being paid. He's being paid $1,200 a month.
He does our negotiations for our managed care contracts for us. He has been doing it for years.
Okay, there's our contract with it?
There was originally a contract, yes. I think it's an ongoing contract.
I haven't seen anything.
We approved, well, I think it was like one of my last.
That goes through the annual stuff, yeah.
Okay, I'm working, okay. So, Chet, we should pay our bills if we can. Now, I know there's a couple in there that the power company and a few things that you're waiting for some resolution some way or other. However, there's some in there that should be paid.
And we agree. And it's like I said, I am working on this stuff like that. I've had some conversations about it as well.
Thank you so much.
We'll bring a plan back to Finance Committee to take a look at.
Okay. So, thanks a lot.
You're not a problem. Appreciate you bringing it up.
Sorry.
Are you done?
No, one other thing. I was talking to you about what you shouldn't do. You're an absolutely awesome director. You're almost as good as John was. Wow. So I thank you, Russ.
Do you want to talk about contractors?
Don't encourage them.
All right. John.
Just a couple of things. First of all, I did want to give kudos to Tim and Chet and Barbara and Gary Hicks for the Cal Mortgage, getting that all paid off. I think that's a big milestone in our district. And I think that the public needs to be aware of that. And that's been 35 years in the making. And it's just, I think it's a relief to see that finally retired. But now it's like what we've discussed tonight is, moving forward from here and getting our revenue up and working forward on these strategic planning initiatives. And again, I hope I didn't irritate anybody with the vote on the budget assumptions. I know everybody puts in a lot of work on this, so I just wanted some clarification on things. But I'm always.
That's why we're here. So good. Great. Good job on that.
Well, and then the issue, like I said, for both you and for Fred, like I said, obviously you had some concerns. So I would still like to hear those after the meeting so that I can answer those questions for you or get the answers if we don't have them. Okay. I want you to feel comfortable with that. So
right. Well, I do. I trust you guys. It was just kind of.
Yeah. And I get that. I just, like I said, but I still want to answer your questions.
Yeah. And I know that we put this off a whole nother month. And and aside from all that, I did want to also give kudos to Ross, because I know Ross has been down there helping with the vaccines at the mobile. And if only I was retired and had the time, I would go down there and help, but I don't have the time. So I do apologize, but thank you, Ross, for helping out with that too as a board member. Anybody else has, I don't know if anybody else has done that, or Catherine or Fred or Gene.
I tried to, they wouldn't let me help.
What a surprise.
Too old.
That's all I had.
I wanted to vaccinate him. That's right.
Thank you, John. Catherine?
I just have a couple of questions. Like, do we still have a bioethics committee?
Yes, we do.
Okay. So, because I haven't ever heard of one lately.
Just met about a week before last or whatever, a couple weeks ago.
Perfect. And as for the van and stuff, after we're kind of got COVID under control, are you guys going to be doing like clinics for immunizations for kids?
So, yes, eventually we've had issues with Kern County Public Health doing their CHDP survey. Like I said, when we're talking about in budget things, the mobile clinic did go out for its first visit at the school. That started yesterday. So we started with two visits, and then it will grow from there, and then it will expand to the Wallace campus. And the school has asked for more physical medicine type things on campus for both students and staff. So
yeah, these are mental health visits, correct? With
now,
Lisa Wiley, right?
Right. Yeah. We could do anything at any time.
Right.
Yeah, I just know in Bakersfield and like Delano and stuff, there's the vans that go out and they do the mobile immunization. Right. So I don't know if that's something that could be integrated, you know, for
we have all of the equipment for it. Perfect. And we've never been really told no, and I've inquired multiple times. So I think it's going to, we bill under the same NPI number. So I think that we'll probably at the beginning of next school year, just start doing it.
Nice. And another thing I wanted to ask is, are we getting an MRI when we go through the new?
No, not planned. Just again, the volume, the cost of them, first of all. And just not enough volume of referrals that we have for those going down the hill.
Okay, people have been asking me, so I thought I'd
love to have one. I mean, I've had them in other hospitals and stuff like that, but usually you've got to have a lot more volume going through. They're very expensive.
Okay.
So,
Tim and our medical staff, at least when we tried before, we asked if they wanted to try to do that locally, and they were not for it at all.
They said most of what they do, they can see with the CT scanner. So, which is one of the reasons why we upgraded to a 64 slice CT scanner. So just to give them a lot more ability to see things.
And then for the pharmacy, I mean, have we thought about doing deliveries? Well, we've talked, I think, about having a drive-through, you know, different things that's going to bring. Those are things that I think Kernville does deliveries, but I don't think Rite Aid does. No one has a drive-through. I just think those are things that
Kernville had it and dropped it. The deliveries. Correct, right. Nobody has a drive-through. We've had some conversations about it. You know, we are looking at some of those kinds of things, but.
And the reason I bring them up is I want to stay positive and look at, okay, what are the things that we can do to help bring the revenue in? Maybe, you know, maybe you can deliver meds when you're going to the school and just meet you there or something. Just kidding. But I'm just thinking anything, you know, things that would enhance the products that we are trying to provide and the services we're trying to provide. I think with COVID, people are okay. There's a lot of people okay and still do not want to leave home. I mean, they're still not really comfortable going to doctors and stuff. I mean, I talk to them all the day, you know, during the day, but young mamas with new babies, they're like, you know, we haven't, so it's hard. So I'm just trying to think of things that.
This is one thing, like I said, that we're looking at some kind of a home care program. You know, we've gone around on this as to whether it should be a full blown home health program or whether it should be more of a visiting nurse type thing. I know Kern Health Systems reached out to us asking us to develop a program up here because they don't have one for their patients up here. BFMC also came and met with me about the same thing, asking if we would either develop a program or do something off contract, you know, with a separate contract that to take care of their patients and go see them at home, those that couldn't get to the doctors or whatever. So that's something I've been with Shannon on and asked her to come up with some ideas as to how we might do that.
Okay.
So yeah, that is an unmet need. And again, that was one of the things that I got talking to Kern Health Systems about was the money to maybe to pay for a van or driver to go do some of these kinds of things as well.
Okay.
So,
well, thanks everybody. I know you've been putting up with me and listening to my questions and stuff, but
welcome.
It really is a privilege to sit on this board. It's not always fun or, not that it's not fun, but yeah, I'm just really pleased that I did get elected and that I'm here because it's eye-opening in a lot of ways. How excited people get about numbers is one of them. And I just really think as a team, there's things that we can do to make things better. I'm sometimes like, I never see Fred or talk to him. I know we can't talk more than 2 at a time. So I feel like somebody's not telling me something. So, and that makes it kind of hard sometimes, but I do appreciate, you know, being able to be here on the board. So that's it.
Thanks, Catherine. Fred.
Catherine, thank you for a lot of your questions. They were items I was going to bring up, but you've clearly already done that for me. Gene, thank you for bringing up the propane. We need to have something in position so we're only paying a set fee above rack price. There's no reason for that to be any higher than it needs to be. It's no different than when we were buying other utilities, example, diesel, when I ran my previous company. Heidi, Barbara, I can't thank you guys enough for jumping in and handling the challenge that the state threw at you in a timely manner.
Yeah, no kidding.
But beyond that, I just want to say thank you to everybody for everything that we all do. And Tim, thank you for being available to answer any extra questions that I have on this.
Anytime.
That we have in front of us.
Anytime.
Thank you.
Thanks, Fred. So it's good to work on this board. I agree with Catherine and all of you. This is it's good to accomplish things as a team, and we're better with all your ideas than without. So
correct.
Please keep providing your input, asking questions, steering me in the right direction when I need that. I do appreciate it. So, you know, the whole propane issue that Gene had brought up, and, you know, there's a potential there for some significant savings. And it kind of brings up a broader issue with the process for purchasing. Do we, you know, the expertise that there is on this board through knowledge of business or in other areas, perhaps insurance, food business, medical supplies and nutrition. You know, there may be other opportunities where staff that are making the purchasing decisions may benefit from insights that we have that nobody would think to ask because we don't see those level of detail. And so I guess where I'm going is there a process by which there can be maybe a committee or maybe just a pilot project where we're looking at purchases as a group with the ability to say, hey, have you checked this out? Have you checked that out? Through our own experiences, our own business experiences, to maybe save some money for the hospital. You know, we need to work on increasing revenue, but we also need to trim expenses. And, you know, that propane is a classic example of where we can be saving some money. And you know, that knowledge was brought forth because a member of our board deals with this in the community and is aware of the issue. So how do we draw on that experience and that information to benefit the hospital? And I guess that's the question I have. So I'll be bringing this up with governance, but any thoughts you have tonight, I'd love to hear them.
Yeah, even contracting like with BFMC and Qualicare and all the rest of them, and I think we just did it. Some of the insurance, and I'm familiar with some of that stuff, and it would be good to have more people involved when we contract to see some advantages or disadvantages of what's going on. And we can't expect Chet to know everything. He does know everything, but we can't expect it from him.
No, you can't. It's too complex. You know, our purchasing person, Ms. Bolito, can't know it all. Chet can't know it all. Tim can't know it all. we've got to be able to draw on that experience somehow without slowing the process down so it becomes too bureaucratic.
Right, right. Just more input lightly or whatever, you know, just to give ideas.
Ross, may I suggest that maybe it's appropriate as an agenda item for a future meeting, as opposed to a general discussion amongst the board members under the board comment agenda item.
Okay, thanks, Scott. Then I'll take that as a cue to shut up.
I was trying to say it as gently as possible.
All right. Then folks, we are adjourned. Thank you for a productive meeting, and we will see you in committees in a couple of weeks.
Have a good day, everybody.
Thanks, everybody.
Good night, everyone.
Thank you.
I was afraid you were gonna like it.